as you're coming in. It is my pleasure to welcome you to our third Bcop session today. It's on the management of CAR T-cell adverse effects and hematologic malignancies. Before we start, a few housekeeping tips. You can find the speaker bios in the app. In addition, we ask that you hold all your questions until the end. In case you don't get all your questions answered today, we have Dr. Shank in the Consult with an Expert time from 12:30 to 1 in the exhibit hall tomorrow, so be sure to reach out to him there. It is my pleasure to introduce you to Dr. Shank. He's a clinical pharmacy specialist in the Department of Lymphoma and Myeloma at MD Anderson Cancer Center. Please give him a warm welcome. Thank you.
Thank you for the introduction. I would like to disclose that I did sit on a Juno advisory board. The objective of this presentation is to describe the efficacy and safety of chimeric antigen receptor, also known as CAR, T-cell therapies. We'll evaluate the signs and symptoms of cytokine release syndrome, known as CRS, and CAR T-cell related encephalopathy syndrome, known as CRESS. We'll categorize the onset of CAR T-cell toxicities following administration, and then using patient case, we'll outline patient-specific supportive care interventions and monitoring plans for CAR T-cell therapies. So starting out as a pharmacist, I never thought I would check a medication that would cost $373,000 to $475,000. This 68 milliliters is worth that much. I used to categorize cancer treatments in the terms of automobiles because most cancer treatments cost $8,000 to $20,000 per cycle, but now I'm categorizing them as houses. So we're going to call these house T cells based off the cost. But more importantly, these have the ability to change cancer treatment, moving away from chemotherapy to these specific gene therapies. So CAR T cells are genetically programmed to bind to transmembrane glycoproteins, and this works as a major histocompatibility complex independent action. So this results in limited off-target effects. As you can see in the right on the table, there's different targets under development. So CD19 we'll spend most of our time with because there's 2 commercially available products. Also CD22, CD33 are in clinical development. We have B-cell maturation antigen, which is in development for multiple myeloma, and then CD20, which we're aware of with other therapies. These are specific to certain types of cancer, and this has led to 2 FDA approvals. So the first one was Tisagen Leclucel, which was approved in August of 2017 in second relapse or later refractory B-cell acute lymphoblastic leukemia and up to age 25, and then Axicaptogene Leclucel, which I'll call Axi-cel, in relapse and refractory B-cell lymphoma after 2 or more lines of systemic therapy in adult patients. The cell structure is complex, but I've simplified it here. On the right, you have the cancer cell, which has the target that I mentioned previously, and then you have the antigen binding domain, which is the blue part, with a single chain variable fragment and a hinge region, which is the black area on the cell membrane. Then you have the yellow area, which is very co-stimulatory domains, which include CD28, 41BB, which is also known as CD137, and a variety of other ones. The first generation CAR T cells included only CD3 zeta, which is for T cell activation. The newer generation 2, which are currently commercially available, have the CD28 or the CD137. There are third generations which would have 2 co-stimulatory domains under development as well. So the production takes about 2 to 4 weeks to process these cells. It starts with isolation through leukapheresis of the patient, and these are the autologous CAR T cells. There's also allogeneic ones as well that are being studied. And we do this without the use of growth factor. Then the cells are sent to the drug company, and they're undergoing manufacturing where a retroviral or lentroviral vector inserts the DNA into the genome. There's also non-viral vector mediated called electroproliferation-based transfection, which is a Sleeping Beauty system is what it's known as. And this has an advantage because it's a little bit faster process time and it reduces the cost, but this has not made it to market. It's still under development. Then the cells will undergo ex vivo expansion and purification, where they'll try to increase the dose to 1 million to 500 million cells, depending on the product. So this will vary based on the size of the patient and the product. Patients then, after the cells are received at the hospital, undergo a conditioning regimen, most commonly with cyclophosphamide and fludarabine. and then the CAR T cells are infused. So there will have to be a pharmacist verification, labeling of the CAR T cells, which at our institution occurs at the bedside, and then the CAR T cells are infused to the patient. Like I mentioned, the conditioning regimens have a use in decreasing the leukocytes, which may interfere with the T adoptive activity. It also decreases the regulatory T cells, and also will have an increase in IL-15 and IL-7, up to a 15 or 13-fold increase in IL-15 and a 2-fold increase in IL-7 after the conditioning chemotherapy. There's also a role of debulking, which leads to greater persistence of the CAR T cells. So patients that have less disease going into them are thought to do better than those that have very active disease. And this will enhance the T cell expression, function, and persistence. The chemotherapy doses that are given do range based on the studies, but the ranges with cyclophosphamide include 250 to 900 milligrams per meter squared per day for 1 to 3 days. Fludarabine in combination with cyclophosphamide is given at 25 to 30 milligrams per meter squared per day for 3 to 4 days. And then bendamustine has been used as well at 90 milligrams per meter squared per day for 2 days. Etoposide has been described limitedly in other studies at a dose of 100 milligrams per meter squared per day. The use of fludarabine is quite controversial. It has been shown to have greater T cell expansion and persistence with the use of fludarabine. It reduces the reaction of the murine single chain fragment on the antibody. Turtle and colleagues compared 13 patients that did not receive fludarabine with 17 patients that did receive fludarabine in combination with cyclophosphamide in ALL patients, and it improved the disease-free survival significantly. You may be aware of Juno's ROCKET study, which looked at JCAR15. There was 3 patients that had cerebral edema. After that, they removed the fludarabine from the conditioning regimen because that was thought to be a factor, but there was 2 more cases after that. One of the patients lived, the other patient was did pass away. Since that time, they've worked on a different product called JCAR17, which is completely different, and some of the differences include it moved from a CD28 co-stimulatory domain to a 4-1BB co-stimulatory domain, and the CD28 co-stimulatory domain is known to have this rapid expansion of the CAR T cells, so that may have been too much. It's almost like it's working too fast for the patient, and the toxicity was just too great. There's also differences in that the JCAR15 includes a turn-off switch with EGFR as well. That one is currently under evaluation. There's other approved products, or all the approved products include fludarabine in the conditioning regimen. There's also the addition of anti-programmed cell death, PD-1 immune checkpoint inhibitors. And this has the same thing, I feel like a broken record, but it's expansion, function, and persistence. That's all what we're trying to do to help make them the most effective that they can be. 4 children with B-cell ALL were experiencing poor expansion and were given pembrolizumab. And the dosing's unknown, but most of the time they're using the labeled dosing for 14 days to 2 months following the CAR T-cell infusion. And this did prolong the detection and overall response rate by 50%. The ZUMA-6 trial is looking at adalimumab, 1,200 milligrams IV for 21 days for 4 doses, and the addition of that for CAR T-cell expansion. In cohort 1, they gave it at day 21, cohort 2 got it at day 14, and cohort 3 got it at day +1. So out of the 5 evaluable patients for response, the overall response rate was 100% with 1 CR. And the area under the curve was 2-fold higher compared to the ZUMA-1 trial. So this is one option, and the commercial products currently are not utilizing the PD-1 inhibitors. I'll go through the literature briefly. This is not a comprehensive overview of all the literature. There's hundreds of articles about CAR T cells, but I wanted to highlight a few trials that are important and ones that we can keep in mind. There's some things that we have to look at when evaluating them. Some of these trials were abstract data that I am using, and then there are some papers. Of course, after the cutoff from the due date of the slides, all the trials came out, especially for leukemia. Luckily, the results didn't change that significantly, but for the terms of the Bcop, what references I have is the ones that I'll cite for this. Factors to consider whenever you're evaluating is the refractory versus relapse disease. The length of follow-up did vary. We're now getting data to 3, 6 months, almost 2 years in some trials. The grading of toxicities did vary. The different centers have defined that as far as the grading for CRESS and CRS. The cell dose varied throughout products, and then they also did dose-finding studies. So you have a phase 1 lead-in to a phase 2, and then they finally found the dose that they wanted, and they moved forward with that. So there's differences in dosing. And then the co-stimulatory domains, it's important to keep an eye out on that because that will help when you're managing the patient. The CRS will occur more or sooner with a CD28 versus a 4-1BB will expand a little slower. There's also, going back to the cell dose, there's a weight-based dosing with some of the treatments versus just a fixed dose. Moving into the efficacy for B-cell ALL, Tisagen-Leclu-cel with the Eliana trial looked at a anti-CD19 with the 4-1BB co-stimulatory domain, and there were 63 children with a CR rate of 83%. At 3 months follow-up with the updated trial that was published, it was 81%, so not much change, but that's a little bit more mature data. And the grade 3 or greater CRS was 48%, 11 deaths, 7 of those being from disease progression. At MSK, there was a study that looked at a CD28 co-stimulatory domain with 51 adults, and this is part of the JCAR study group with complete response rate of 84%. At Fred Hutch, looking at the CD19 with a 4-1BB, and this one does have the truncated EGFR transduced cells, which is hopefully going to be used as a receptor termination switch, in 33 adults with a CR rate of 94%. And then the ZUMA-3 trial, a CD28 co-stimulatory domain, with 16 adults with a CR rate of 73%. Grade 3 or greater CRS was 25% with 1 death due to CRS. I wanted to further look at comparing this with a humanized version. So the CTL019 was a murine single-chain fragment variable region. Mueller and colleagues determined that 35% of these patients develop anti-murine antibodies, so they developed a humanized version of that antibody. So this table depicts a comparison between those as far as the efficacy and safety as well. I do want to note that 16 patients did receive CTL019, and then were also given CT119 humanized cells. So there is some overlap. The CR rates were similar, and then any grade CRS was 78% in the murine group versus 89% in the humanized group. To further look at the patients that already received, so this was their second infusion of the humanized group, there were 16 of those patients that had relapsed or refractory B-cell ALL. 9 patients did have a CR at 1 month, and 7 of those patients were MRD negative. 2 patients were MRD positive at that time, and they progressed at 1.6 and 3 months following CAR T-cell infusion. And then 7 patients didn't have a response. So this might be one area of opportunity that patients might not be responding because if they develop the anti-murine antibodies. Now we'll move to B-cell lymphoma with axicabtagene ciloleucel. With the ZUMA-1 trial was the pivotal trial for this study that brought it to market with a CD28 co-stimulatory domain with 101 evaluable patients. At a median follow-up of 15.4 months, the CR rate was 40%, with grade 3 or greater CRS as 13%, and grade 3 or greater CRESS at 28%. At the Juliet trial, looking at the Tisagen-Leclu-cel with a 4-1BB co-stimulatory domain for 81 patients, the CR rate at 3 months was 32%, CRS was 23% of grade 3 or greater, and CRESS was of grade 3 or greater was 12%. And then the Transcend trial with JCAR17 with the anti-CD19 and with the 4-1BB co-stimulatory domain, and this one also did have the EGFR termination switch as well. There was 68 patients available for the efficacy endpoints with a CR rate of 40% at 3 months. Any grade CRS was 30%, and grade 4 CRS was 1%, and grade 3 or greater CRESS 14%. So it's difficult to make comparisons, but the trend in the CR rates between even leukemia and then the lymphoma seems like the studies are similar. The toxicities we don't know completely yet because the sample sizes are relatively small with these patients of about 50 to 100 patients. Now we'll move to chronic lymphocytic leukemia, which looked at Tisagen-Leclu-cel with the 4-1BB of co-stimulatory domain with 30 patients evaluated for efficacy with a CR rate of 23%. CRS, any grade, was 54%. And then at the Fred Hutch with the CD137, which would be the 4-1BB co-stimulatory domain, 12 patients with a CR rate of 50%. Moving to myeloma, there is some overlap. Although myeloma is not expected to have CD19 expression, they did try to give patients, there was 10 patients that got the CTL019, which is an anti-CD19 antibody with the 4-1BB co-stimulatory domain. With 10 patients who were progression-free, it was 60%. There was some grade 1 CRS at 10%. And these cells were given following an autologous stem cell transplant. Moving to the newer targets in multiple myeloma, the anti-BCMA, with Bluebird, there was 18 patients who were evaluated for efficacy with an overall response rate of 89%. Grade 1 or 2 CRS was 71%, and grade 3 or greater, or grade 3 CRS was 10%. Legend Biotech published 19 patients. They did not publish their co-stimulatory domains. I was unable to find that information. And the patients got a CR, near CR of 95%, with grade 1 or 4 CRS of 74% and grade 3 or greater 11%. And then NCI, there's an anti-BCMA with a CD28 co-stimulatory domain with 11 patients evaluated for efficacy that had a complete response or a very good response at 64%, with grade 3 or greater CRS of 42%. So the myeloma data is not as mature as with our leukemia and lymphoma data, but it is showing promising results as they're expanding them to phase 2 trials. So in summary, more studies are needed to determine the role of fludarabine in the conditioning regimen for chemotherapy. Efficacy outpoints demonstrate promising results in this heavily pretreated population, often with very few options, and variations in length of follow-up makes these comparisons between trials difficult. Grade 1 to 2 CRS occurs commonly, but reporting does vary between the studies. So this brings us to our first question. Which of the following is an accurate description comparing CAR T-cell studies? Appropriate follow-up has been reached for the primary efficacy endpoints. Cross-study comparisons of efficacy and safety can be made between studies. Patient populations in B-cell lymphoma and acute lymphoblastic leukemia were consistent among trials. Reporting of grade of cytokine release syndrome varied across studies. Okay, we'll see what the answer is. Correct. D is the correct answer because the grading did vary. The next common answer was C, which the patient populations did vary between the studies. With refractory versus relapse, there was some differences in the studies. Now we'll move to the fun part, which is the presentation and management of the toxicities. So this will be the meat of the discussion that we'll be having. And to start off, we'll start with the infusion reactions, which are rare but can occur, and it's your normal infusion reactions that we're used to: fever, chills, nausea, vomiting. In clinical practice, I haven't had very many infusion reactions. I actually had the opposite when we gave somebody a large dose of Benadryl and then they were sleepy and kind of, we were worried about even giving the cells at that point, so we had to wait for it to wear off. So just being cautious with your dose, maybe go with a half dose in someone that's a little older, because you felt silly then that we're delaying cells for our pre-medications that we gave. You can give Tylenol, and then, like I mentioned, Benadryl, and then we can give, some people will give Claritin as well. And you do definitely avoid the corticosteroids at this time. For avoiding corticosteroids, we do put a banner up on top of the patient in an allergy, so any person verifying orders, seeing the patient will see this alert, so that they will not inadvertently overnight be given steroids. With immune toxicities, it's categorized into two: the cytokine-associated and then the autoimmune. The cytokines related to the CRS and CRESS, and this is a non-antigen-specific toxicity, and it does have a high level of immune activation. And then the autoimmune would be an antigen-specific. So an example of this would be using the murine versus humanized product, and those 34% of the patients that did have antibodies against the murine. This can be on-target and or off-target toxicities, and the antigen expression is on non-malignant tumors. There can be CD19 independent, which examples of that would be chemotherapy, anaphylaxis, or transformation. And then the CD19 dependent would be CRS, neurotoxicity, and tumor lysis syndrome. Would be some more examples. I've developed a timeline, and the exact days are not specific. This is generalizations, but I wanted to visualize in your mind of how these toxicities present. So we start at day -5 and then go to day +30, and this is of the CAR T-cell infusion. And they'll get their conditioning regimen depending on the protocol at the beginning, at day -5, day -3, and some combination depending on what the specific protocol is. And then the infusion for us would occur on day 0 or day -1. At the time of the conditioning regimen to the infusion, at the bottom you can see they're at risk for tumor lysis syndrome, infection, nausea, vomiting. And then following the CAR T-cell infusion, they'll be at risk for CRS, CRESS. They'll develop hematologic toxicities as a result of the conditioning regimen kind of becoming where they're natering for that, and headaches can occur. You'll also have late onset CRS, which is distinct from the acute onset CRS. It's a biphasic presentation that it can occur. And then you'll have your late toxicities, the B-cell aplasia, you'll have infections, viruses, you can have VCV, hepatitis reactivation, and other bacterial and fungal infection risks. So this brings us to our next question. Which of the following is the correct order of onset of the CAR T-cell toxicities in order from day 0 to day greater than +3? CRS, infusion reactions, nausea, VCV, tumor lysis syndrome, hematologic, late onset CRESS, low IgG level, VCV, CRESS, tumor lysis syndrome. We made it to 152 last time, so, 160, man, we're doing real good here. Okay, in the essence of time, even though I'm having fun up here, the correct answer is C for the onset of them. So it'd be hematologic, late onset CRESS, and then the low IgG level, which is the B-cell aplasia connecting that. So moving into the toxicities of CAR T-cell, I wanted to give an illustration of the types of toxicities and the rates. I used one example. This is a lymphoma example, and it does vary between studies, products, cell doses, amounts, disease state, and population. But this will represent the main toxicities: neutropenia, thrombocytopenia, and anemia, all supported with supportive care. Febrile neutropenia occurred at 31%. CRESS, which will also be referred to as neurotoxicity. I don't think I mentioned that, but interchangeable terms, if you're questioning that, of 28%, and then CRS, 13%. So the onset will vary between the products. Like I said, the 4-1BB will be slightly delayed around day 5, versus with the CD28, the peak will be day 2 or 3 of the expansion. The pathophysiology of CRESS and CRS is a rapid release of inflammatory cytokines, so TNF-alpha, IL-6, which is important because we have drug therapy for that, IL-8, IL-10, IL-15, and many others. This is just a small list of them. The risk factors include large tumor burden, early onset, less than 3 days, multiple comorbidities, older age. So in our patient population with the lymphoma patients, they can be of higher age in their 60s or 70s. And then an elevated C-reactive protein prior to the CAR T-cell infusion, and this is a CRP rate of greater than 20. So some of our patients are coming in at 100 or 150 because they have active disease. And the CRP is a non-specific marker, but it's been shown to be a predictor of severe CRS. So severe CRS was defined where on the y-axis you can see CRP, and the x-axis the day post-transplant. The dark black line is the severe CRS, and then the gray line is non-severe CRS. Severe CRS was defined as fever greater than 3 days consecutively, a 75-fold increase of 2 cytokines, or a 250-fold increase of 1 cytokine. And the cytokines they looked at were IL-15, IL-6, IL-2, IL-10, were other cytokines, as well as IL-5, IL-6, interferon gamma. So some of these were run to see the risk factors. And they had to have 1 sign of toxicity. So the hallmark signs is hypotension, hypoxia, neurologic disorder for that. So this left a threshold of 20. So for me, this is a surrogate endpoint. It's not absolute, but as far as when patients are starting to possibly develop CRS, if you see the CRP rising, then you have to be more vigilant in your monitoring. So it's 1 lab parameter. I hope we get many more, but this is one that's readily available for us to use. Ferritin's another lab marker that we can use, but if they have an infection, that's non-specific as well, but it's what we have, so interpreting both of those and seeing the trajectories of those, I always graph it, and it looks really cool. If you have any learners on your rotations, if you can show them a graph of the CRP, it really depicts what's happening. So going more into the CRS, it occurs in the first 3 weeks. It's characterized by hypotension, organ toxicity. So this requires a multidisciplinary approach. You'll have neurology, cardiology, you can have renal on board, ICU, whatever the needs of the patient, and then a fever and hypoxia, which these transvert into the grading as well. So temperature greater than 38 degrees for any grade, systolic blood pressure less than 90 millimeters of mercury. Grade 2 would be if it's responsive to fluid boluses or low-dose vasopressors, which you can see in the footnote below, and the vasopressor has to be on for 3 hours or greater as defined. Or grade 3 would be requires high-dose vasopressors or multiple vasopressors. Grade 4 would be life-threatening. And then the need for oxygen, so an FiO2 of less than 40 is grade 2, greater is grade 3, and then requiring mechanical ventilation would be grade 4. Organ toxicities, if they develop grade 3 of any organ except for the elevated liver function would be grade 3, and then the grade 4 would be similar to grade 4, so that makes a lot of sense. I'm going to spend time on using the CAR-TOX algorithm, is what I'll be, which is done by Nilapu and colleagues at MD Anderson. It's very similar to the Lee and colleagues that was developed at UPenn. There are some differences. At the end, I'll discuss the differences and compare those for everyone so you can see kind of the distinct differences. The package inserts for both of the commercially available products do have guidance as well. So for grade 3, if they develop a fever, you can get cultures. We have as needed acetaminophen. If they're neutropenic, we'll start growth factor if they didn't already start this. This can be per protocol. Some treatments do not allow the growth factor. We do use it with our AxiCell. You can use a hypothermia blanket, broad-spectrum antibiotics. Organ toxicity is all symptomatic management. And if they do have a refractory fever of greater than 3 days, we can consider the use of tocilizumab or cetuximab at this point. Moving to grade 2, the hypotension, you'd give fluid boluses. After 2 boluses, if they are still hypotensive, you can consider anti-IL-6 therapy. You would start low-dose pressors. Usually we would assess about 12 hours after that. It does vary depending on what algorithm, but 12 to 24 hours after the tocilizumab administration to start dexamethasone. If patients are at high risk, so they have bulky disease, multiple comorbidities, or early onset, we'd consider going to the dex a little bit faster. Organ toxicity would be the symptomatic management. You can add in the IL-6 therapy as well. And hypoxia, we would add in supplemental oxygen and supportive care measures. Moving to grade 3, you would manage the hypotension similar to grade 2. With the addition now, you would add dexamethasone 10 milligrams IV every 6 hours. If they are refractory, you can increase that to 20 milligrams IV every 6 hours. And then using multiple vasopressors as needed. The patient would definitely be in the ICU at this point, obviously, because of the pressors. With grade 2, you can consider the transfer. We usually tee them up and get the ICU aware of the patient so it's not a rush. And then if they do need to go down, then they'll be in the ICU. Hypoxia, you'll have high-flow oxygen, and you can use non-invasive positive pressure ventilation. You can still consider the IL-6 therapy and dex as well, and symptomatic management. Moving to the most severe, grade 4, the hypotension, we would increase the dose of the steroids to methylprednisolone, 1 gram IV every day, which I usually split out to 500 milligrams IV every 12 hours. Organ toxicity, you can do symptomatic management, anti-IL-6 therapy, you could repeat doses if needed, and mechanical ventilation at this point. So the anti-IL-6 therapy, I'd like to tell a story before of how this was developed. I think it makes it very memorable. In Philadelphia, my old stomping grounds, there was a patient that was the first patient treated at CHOP in combination with University of Pennsylvania. So if anyone's there that works there, they can probably tell the story better than me. But Emily Whitehead was the first patient that received the therapy. And after that, she had to be transferred to the ICU and was doing very poorly. They did send the IL-6 level, which came back very elevated. Carl June is a researcher and translational scientist who's been the pioneer in this CAR T-cell development program up there, and his daughter has rheumatoid arthritis and was getting tocilizumab administered, and said to the treating physicians at CHUP and UPenn that they could consider giving tocilizumab. And when I was reading this article, I envisioned this happening on a Friday at 3 p.m. I just knew it was going to be, and it was probably the 13th too, but I don't know about that. That's all anecdotal. But I think I was reading this and I was like, this would definitely happen to me on Friday. But luckily for her, she turned around very rapidly after the tocilizumab administration. So that kind of set the stage for us using this therapy. So tocilizumab binds directly to the IL-6 receptors, and the serum IL-6 receptor levels do increase after tocilizumab administration. Lee and colleagues demonstrated this, and even following the second dose of tocilizumab, it would also increase as well. And this can lead to rises in central nervous system concentrations of IL-6. Theoretically, that would make it worse, the CREST and CRS as well. On the right, you can see a table that depicts the binding affinity for IL-6 to the receptor and tocilizumab to the receptor. So this binding affinity, since tocilizumab binds directly to IL-6 receptor, it increases IL-6, and then more IL-6 in the CNS, and then that'd be worse. So the lower KD is a higher binding affinity. So this might be a reason why we give more than one dose of tocilizumab to kind of overcome this concentration and maybe compete for the site, the IL-6 receptor, if you can double the concentration. So you'll see the half-life in children is 16 to 23 days, and in adults after a single dose is 6 days or 13 days. But this is with normal concentration. So if you give 2 doses, there's been studies showed in the pediatric patient population that the total increase in the peak level was almost doubled. The AUC was significantly increased. They weren't able to make statistical comparisons, but they did summarize that there was a definite increase. So that might be a reason to give the second dose. And then siltuximab, which does not bind to the receptor, it binds directly to IL-6. So this might be a theoretic benefit of siltuximab. There is no FDA indication for siltuximab for CRS. So tocilizumab did get the indication whenever tisagen lacluzole was brought to market. So that was your ability to be able to use that would be your first-line agent. In practice, we use 2 doses of tocilizumab, and then after that, we'll consider a dose of siltuximab if needed. More into the differences in the agents. So tocilizumab, like I mentioned, binds to the soluble and membrane-bound IL-6 receptors. For patients that weigh less than 30 kilos, it's 12 milligrams per kilo. And those that weigh greater than 30, it's 8 milligrams per kilo. IV every 6 to 8 hours. The FDA label says 8 hours, and the CAR-Tox guidelines gave a 6-hour interval. A max of 3 doses in 24 hours, and a max of 4 doses total, with a daily max of no more than 800 milligrams per dose. As far as adjustment and adverse effects, in this instance, it really doesn't matter because CRS is much worse than anything, but there has been some infusion reactions. And the cost can be significant, so when you're budgeting for these patients to come in and you're considering up to 4 doses or 3 doses, it's $3,300, just the wholesale price, not even administered to the patient per dose. So this can add some significant costs to the whole CAR T-cell treatment. Siltuximab, like I mentioned, binds directly to IL-6. It's given at 11 milligrams per kilogram, and we would only give 1 dose of siltuximab. Infusion reactions can be seen as well, and the cost is $8,200. So if you have to give 2 doses of tozi and siltuximab, you're adding a significant cost, as I mentioned. Now we'll move into the distribution of CRS. There's one trial that was done by Hay and colleagues that looked at 133 patients, and this was a combination of B-cell ALL, non-Hodgkin's lymphoma, and CLL. These patients did receive the CD137, which is the 4-1BB costimulatory domain anti-CD19 cells. And most of the patients had grade 1 or 2 CRS with 26 and 32%. Respectively. Grade 3, 4, and 5 were rare, and they did have 5 deaths in the first 30 days, and they were from CRS and CREST related to that. In the same patient population, you can see the red line is severe CRS, the gold or yellow is grade 1 to 3, and then the blue is grade 0. On the y-axis is temperature, x-axis is date from CAR T-cell infusion. You can see those that were severe, those that had grade 4 and 5, had a statistically significant earlier presentation, higher temperature peak, and also longer duration with that. So the temperature really does predict the toxicities with that. There was a multivariate analysis done which looked at tumor burden, which was statistically significant in both the univariate and multivariate. There's different selection methodologies, so the CD8 cells. Some of the products are done in ratios, so the JCAR 017 has a ratio of a CD4 to CD8. It's matched at a 1-to-1, where some of these other products are just a bulk. It can be any combination of those cells. So this more selected product did favor better. Severe thrombocytopenia was found to be significant in the multivariate, but didn't quite reach it. In the univariate, but did not reach it in the multivariate. Higher CAR T cell dose was significant in both the univariate and multivariate. And then when done in combination with fludarabine, it did show to be significant. Cyclophosphamide and fludarabine, though, in the univariate was not significant, but then in the multivariate did fall out to be significant. Looking at this same population with the patients that did receive tocilizumab, so fever resolved in about a half a day following therapy, and it correlated between the CAR T cell levels and the serum IL-6 levels. These patients did require vasopressors and intubation at a rate of 8%. Of the 26 patients that did receive treatment, 20 received the combination of tocilizumab and dexamethasone, and 1 patient had tocilizumab alone. 5 patients got dexamethasone alone. So there is different combinations, and depending on how fast they deteriorate, sometimes you don't have time to wait for the tocilizumab the full 24 hours, and you may feel compelled to start the dex if they move to a grade 3 instead of waiting the full period of time. Earlier on in the clinical development, we were what I call stingy on the use of tocilizumab because we thought that it would inhibit the CAR T cell expansion. And since then, the data actually shows otherwise, that it does not tend to impact it. So this table shows the median peak of CAR T cells and the median AUC of patients that received tocilizumab with those who did versus not. In order for them to receive tocilizumab, they would have had to have CRS or CRESS combination. And there was no difference in their complete remission rates. One thing that was interesting is the peak and AUC was both higher in those that received tocilizumab. And it wasn't because the tocilizumab was causing the peak to be higher. The patient had a higher peak, more toxicity, and then required tocilizumab administration. But it was interesting to note that it does not seem to impact the expansion of the CAR T cells, which was initially thought that could cause a problem. Now we'll move into our corticosteroids, which is hoped to, it's given in an effort to reduce cytokine release and to prevent the toxicities, suppress the inflammation, and induce the T cell apoptosis. The corticosteroids may impair the CAR T cell function, and we want to initiate steroids for grade 2 CRS about 24 hours after the anti-IL-6 therapy if the symptoms worsen. So that window, there's nothing set in stone, but I would say about 12 to 24 hours from there. And you'll continue the corticosteroids until resolution of symptoms to grade 1, and then you taper quickly 3 to 6 days to try to get them off as fast as possible. Some of our patients that I've had that have had severe CRS required a very long course of very high doses, so the 500 milligrams IV every 12 hours. And in those patients, I would do a slower taper for adrenal insufficiency. But the idea is maybe if you get a little adrenal insufficiency, you just monitor for it and then increase or give them some supplemental dose just to get them off as fast as you can. For the dosing of the steroids, similar to the algorithm that I went over, dexamethasone 10 milligrams IV every 6 hours. And then if they're refractory, you can increase to 20 milligrams IV every 6 hours. The methylprednisolone, I would start at 500 milligrams IV every 12 hours for grade 4, and then I have a taper here. We happen to not provide the taper in the literature for the dexamethasone, so you get to make that one up on your own. On rounds, I'm always kind of just thinking of what you want to do, and then we usually make up something and then talk about it, but it's usually always over 3 to 6 days. And then if they're getting CRESS, you would give it if they're refractory to anti-IL-6 therapy after 24 hours, or CRESS without concurrent CRS. So if it's CRS with CRESS, you can give Tozi and steroids. If it's CRESS alone, it's dexamethasone first. Similarly, with the Zuma 1 trial comparison that we looked at with Tozi, this is the same thing, the median CAR T cell peak, and then as well as the AUC. And although these didn't reach statistical significance, you can see the numeric trends from 32 to 50 of the CAR T cell peak, and a 480 to 725. So these patients that required corticosteroids did have greater expansion, and it doesn't appear that the corticosteroids did decrease the expansion. At least it wasn't significantly found, or there was a trend towards the opposite, actually. There's many other organ toxicities. Like the list is very long, so you can have cardiac, respiratory, gastrointestinal, hepatic, renal, coagulopathy, hemophagocytic lymphohistiocytosis, rashes. So there's many other toxicities. This requires a multidisciplinary approach with these patients. We have subspecialists that are trained in the CAR tox. They follow in all these areas to help support these patients. Now the fun part, we get a patient case. AS is a 43-year-old female with a past medical history of stage 4 refractory B-cell lymphoma, seasonal allergies, hypertension with no known drug allergies. She is day +2 of anti-CAR T cells. Overnight events include fever of 39.5, hypotension of 80, systolic blood pressure of 84. The nocturnal team did order blood cultures, X-ray, and 2 fluid boluses. It resulted in an improvement to systolic blood pressure of 88, temperature remained 39, and the patient was awake and alert ×3. So what interventions are appropriate for AS at this time? Dexamethasone, neurology consult, acetaminophen, repeat fluid boluses, acetaminophen, cooling blanket, repeat fluid bolus, acetaminophen, neurology consult, tocilizumab, cooling blanket, and acetaminophen. I think some people slept because we were up to 170 last time, but we'll keep on going along. So we have a little bit of a mixed response, some controversy, good. So we'll work through the the patient didn't have altered mental status or signs of CRESS for that. And you can push back and say, I did not give you the CAR toxicity score, so I agree. Then I didn't want to have that on there and you not know what to do with it because we're going to talk about it in a little bit. You already gave 2 fluid boluses, so B, when continuing to give them, they may need more, but you would have to give Tozi at that point. C wasn't very popular, and D is correct. So I'd give tocilizumab, you'd have the cooling blanket and Tylenol, it's all supportive care. Now we'll move into CRESS, which is characterized as seizures, the neurologic assessment, which is their orientation, naming objects, writing, and counting. They can have motor weaknesses and the raised ICP with this. Like I mentioned, CRESS is biphasic, so the first phase could be a high fever with other CRS as well, and that's related to the cytokines. Or it could be after the CRS resolved at 3 weeks, around 3 to 4, and it would be due to the CAR T cells in the CNS actually being active at that time. Usually, in my experience, the late onset has been self-limiting, but others have described it where it's been more active, so I think that may depend on product as well. Our patients would have been discharged by then, so but some of them we would readmit and evaluate if it's so severe. The cytokines related to the CRESS is IL-6 and IL-15, and we started with mini mental status exams, and then we moved to the CAR tox assessment. In pediatric patient populations, you're probably familiar with the Cornell assessment of pediatric delirium, which has been used to. We'll go through the grading distribution. This is the similar patient population of B-cell ALL, non-Hodgkin's lymphoma, and CLL. The CRESS presentation was a median 4 days after CAR T-cell infusion, and the peak was 2 days after the initial presentation. So you do have some time to do your assessment from there. It's not like they tank right away, but sometimes they can. So that's a median, so there's outliers. So just be very vigilant in your assessments and have flow sheets and make sure the assessments are being done. We also have neurology following along and doing their assessments as well. Our mid-levels will do the other assessment. And then the grading, so you have the neurologic assessment score. The CAR tox is 5 points for year, month, city, hospital, and president, which I don't know, I think I'd get 4 on an average day. But and then 3 for naming objects, writing a sentence. If they could read my sentence, then I guess I'd get a point for that. And then counting backwards by tens from 100 as the assessment we do. So we track this, and you can see the trajectory with it. For the raised ICP, starting at grade 3, stage 1 to 2 papilledema, or CNS opening pressure of less than 20. If it's stage 3 or greater of the papilledema, CSF opening pressure of greater than 20, or cerebral edema would be all grade 4. If they have seizures, so the partial seizure or non-convulsive seizures responsive to benzodiazepines would be grade 3, and then generalized seizures with convulsive or non-convulsive status would be grade 4. So it can be variable. Grade 1, we always put them on aspiration precautions. We'll avoid CNS depressant meds. So we have specific admission orders that will stay away from the sedating nausea medications. We won't give them any sleeping aids as well during this period of time, just so you don't confound it. If somebody gets Ambien the night before and then they develop it, everyone's looking at me and like, why did you give them Ambien? I'm like, well, it was on the admission order. So now I just get rid of it and it's never a problem. You get a neurology assessment, consider IL-6 therapy only if they have CRS with it, and then the seizure treatment, which we'll go into. Stage 2 would be the same. You move to the dexamethasone if they have CRESS alone, the same dosing that we discussed of 10 milligrams IV every 6 hours, and then the higher dose, or methylprednisolone can be used as a weight base as well, of 1 milligram per kilo every 12 hours. Some places you'll find it with methylprednisolone, 2 milligrams per kilo as well every 12 hours is another dose that I've seen described in the literature. At stage 2, we're going to consider an ICU transfer, so you start letting them know so they know they might be a potential being on their way down soon. With grade 3 CRESS, you manage very similar to grade 2. With this time, you would always get your CT, MRI. We get ophthalmology and neurology to come by and do full assessments stat. So they'll assess for papilledema, and then the opening pressure, we may need an LP as well. Going to stage 4, we'll use our high doses of steroids with the methylprednisolone of 500 milligrams every 12 hours for 3 days. If they have status, I'll go over that management as well as papilledema. And this, for sure, they'll be in the ICU and likely intubated. The management of the elevated ICP, we start with acetazolamide, 1,000 milligrams IV, followed by 250 to 1,000 milligrams IV every 12 hours for stage 1 to 2. Moving to stage 3, 4, and 5, or CSF opening pressure greater than 20. The high-dose steroids at this point. You can give mannitol, hypertonic saline. You'd elevate the head of the bed, or hyperventilation are all strategies that can be implemented at this time. For seizure prevention, all of our patients start levetiracetam. Prior to the CAR T cells, they'll start the day of 750 milligrams twice a day, and this continues till day 30, and then we taper for 3 days. You can, for non-convulsive, if they're having that, you can do lorazepam. You'll give them another loading dose of levetiracetam, it's 500 milligrams, and then consider phenobarbital as well. And then you'll follow that by maintenance, lorazepam, levetiracetam, and phenobarbital. And we usually have neurology finding and following, and they'll provide these recommendations. For convulsive status, it's the same thing, lorazepam, just higher doses. You still give the bolus, levetiracetam, and then you consider the phenobarbital at a weight-based dosing, and then you follow that by maintenance. So like I promised at the beginning, I will compare, since I favor the CAR-TOX algorithm, to the other product inserts as well as the other methods. NCCN also released guidelines after the cutoff for management as well. This talk did not summarize or include any of those recommendations as well. So just that's the caveat. I am aware, but we'll compare and contrast with the product labeling. So Tisagen, Leclucel. One major difference is the tocilizumab followed by methylprednisolone, the 2 milligram dose that I stated for resistant CRS, and you'd repeat tocilizumab at 24 hours after. This doesn't differentiate CRESS management or any neurologic management. It's only for the CRS in their description. They do like to limit the use of GM-CSF, which we rarely use, but you would want to stay away from that because that is one of the cytokines that could be released. So the Axicell and CAR-TOX working group is very similar overlap with the management. So CRESS without concurrent CRS, you'll start with corticosteroids. It's a very important point. I think I've said it 3 times, so I just wanted to reiterate that one. Tocilizumab can be repeated in 6 hours using the CAR-TOX algorithm, 8 hours with the FDA, and then there's others that's 24 hours. So I've given you the whole realm of possibilities. I think clinically it all happens so fast, and you just make your judgment. I think 8 hours is a good place to start because you get the drug in. It takes an hour to make, get, administer, absorb, and then work. So you give a few hours. I think 8 hours seems reasonable, but if they're doing poorly and they progress to where you'd give them steroids, you can start steroids because you can always stop them. So kind of erring on that side. And then the grading for Tisagen Lec-Lucel, the grading that they use instead of grade 1 through 4, they call it a prodromal, avert CRS, life-threatening CRS, and resistant CRS. So it's a little different terminology that's used. With your staff at a hospital, having all these different algorithms following the package inserts can be challenging, especially if the same service would take care of both patients. So I think finding one mechanism that works for all would be a very helpful and safe practice for the patients. Now we'll be moving away from CRS and CRESS, which were my two favorite, but we have some others to talk about. So hemophagocytic lymphohistiocytosis and macrophage activation syndrome is a very similar presentation as CRS. So you'll have hyperactivation of macrophages and pro-inflammatory cytokines, which will present to fever, multi-disorgan dysfunction, CNS disturbances, elevated LDH, and low fibrinogen. The diagnostic criteria is the ferritin being elevated, and then you'll have grade 3 or greater liver function. You can have elevated serum creatinine, pulmonary edema, or mostly this is the most helpful as a diagnostic. So having hemophagocytosis in the bone marrow would be the diagnostic. So our treatment would be fibrinogen concentrate and cryoprecipitate with this. So if it's grade 3 or greater, we'll start with anti-IL-6 therapy and corticosteroids. If there's no improvement in 40 hours, you can consider adding etoposide and consider IT cytarabine only if they have neurotoxicity present. And one thing I forgot to mention is for the management of CRS and CRESS, there's other more elaborate reversals, such as giving Cytoxan or anti-RACAM or something to reverse the CAR T cells. That I have very limited experience with that, but that would be an option if you were in a life-threatening instance. There's been reports of that options as well. So moving to some short-term adverse effects, you can have tumor lysis syndrome. So our patients will start allopurinol prior and continue through expansion. Especially, you just follow their uric acid level. I wait 7 to 10 days, and then I'll stop it, usually before discharge, so I don't have to give them a prescription, since it's very unlikely that I've had no experience with getting patients that actually have rabid tumor lysis syndrome. Usually not a problem. Fevers is very common. It's always cultures, many broad-spectrum antibiotics, possibly antifungals, having ID consults, and imaging in case they have pneumonia. The headaches are the most challenging one. It should be the most simplest to treat, but as far as using medications that don't cause CNS depression is very difficult. I usually try to start with tramadol or Furoset would be my two go-tos, but then if you give them straight caffeine at a high enough dose, then they get tachycardic, and then you don't know if they're in sepsis or not. So kind of very small doses, maybe a soda or something instead, but they can be difficult to treat. You have nausea, vomiting can occur. We'd use ondansetron as our first choice, except for if they had headaches, then we would substitute. Hematologic toxicities, they can have neutropenia, which we would support with filgrastim. Our patients start at day -1 and continue through, and then they usually improve, and then it takes a few times when they'll drop down, so they may need PRN doses after that, as well as being outpatient. And for Tisagen Lec-Lucel, the GM-CSF after the first 2 weeks, or if it takes 3 weeks where they can't have it, or if CRS has resolved as far as per package insert. And then thrombocytopenia can occur and anemia, so you just support them with blood products. And they'll need follow-up in the outpatient because this could be recurrent effects. Moving to the intermediate to long-term effects, so the infections. So I mentioned hepatitis. You can have, that will have viral infections with influenza, recurrent coming in. So you just have to support these patients long-term, especially if they have persistent B-cell aplasia. You really need to monitor them. You have the hematologic toxicities, as I mentioned, prolonged. They may need infusions for quite some time. And then the B-cell aplasia with having the low IgG levels. So because they have fewer plasma cells circulating, so their antibody production's low, so you need to monitor the levels. There's no real consensus guideline. My reference is the supplemental material for the protocols, and they vaguely discuss the use of IVIG. They just haven't given specifics. I think it's but we were following the less than 400 is a rough estimate for that. So you will need to obtain insurance approval outpatient and make sure that's covered before giving. So that's usually at day 30 or 60, you'd be checking these levels at least monthly and then going from there. So there's many interventions, more than what could fit on this slide, but I highlighted a few. So first, you want to avoid drugs that cause CNS depression, both on admit and then following up afterwards until they're out of the window of CRS. Some patients are on a large dose of pain medication, so weaning that off and dealing with that, especially if they need to go to the ICU and be intubated, and preventing withdrawals. So you want to monitor that, because if they have really bad disease coming in, they may be on a lot of around-the-clock pain medications. You want to assess for drug interactions and the excluded medications, so the steroids, as I mentioned. Sometimes they get a lot of blood products, so you just have to watch and train your staff not to write for the hydrocortisone prior to that. And you want to avoid the NSAIDs as well, except for if they're refractory, we can use NSAIDs only if they don't have any contraindications. So if you're giving Tylenol and the cooling blanket's on and they're still not able to break the fever, you could give them some NSAIDs as well. Usually I use naproxen, but it's whatever you prefer. You can select and deselect antibiotics. So starting the initial therapy, we'll put patients where they come in they'll have the standing antibiotics that were selected and already dosed that just need to be activated at that time, which goes with a neutropenic, kind of febrile neutropenic order set that many of you have. You can have these on standby, so the doses are kind of the doses that are correct before, so someone overnight's not trying to make up a regimen for you. You have vaccines. As far as live vaccines, there is recommendations to avoid those around CAR T cells. Follow-up vaccines, there hasn't been a schedule, but I would imagine it's going to be similar to an autologous stem cell transplant. As far as discharge, you need to make sure you fulfill all the REMS program requirements, giving them a wallet card, which would be given at the infusion, and documentation of that. And you want to inform the patient, since there's a lentiviral vector that's used for the genome insertion of the CAR T cells, there's some reports that it could cause a positive HIV test. It'd be a false positive. So just letting the patient know, just in case, that they would need further testing to do that, especially in the young patients where it'd be on common screening tests. So moving to a patient case, TS is a 41-year-old male with a past medical history of stage 4 refractory B-cell lymphoma with depression with no known drug allergies. Is currently in day -1 of anti-CAR T cells. You can see the medications listed on the right. These are all the admit orders. TS is scheduled to be admitted today. What interventions would you make at this time? Change promethazine to a danzatron 8 milligrams IV every 8 hours as needed for nausea and vomiting. Recommend to add lorazepam 0.5 milligrams every 6 hours as needed for anxiety. Stop acetaminophen and start naproxen 250 milligrams every 8 hours as needed for temperature greater than 38. Stop lisinopril and continue hydrochlorothiazide with a systolic blood pressure holding parameter less than 110. I think we can break some records in the numbers. So I think it was 172. Everyone's probably getting tired of the app, or your battery on your phone died, which mine did yesterday. Oh, we did, good. Strong work. Okay. So A is correct. So we try to avoid the sedating, nausea medications. D was a little bit of a trick, and when I was developing this, we had a round table in the office, and I was like, is this too mean? So if you have tomatoes, please, you can throw them at me, I guess. So if tumor lysis syndrome's a risk, you could hold the hydrochlorothiazide. I know it's a soft call, but I couldn't think of anything better. So the interventions, you have antimicrobial prophylaxis. Per our CARTOX guidelines, it usually follows an autologous prophylaxis for that. So start fluconazole if expected to be neutropenic for greater than 2 weeks, which they typically tend not to be, so that's not something we normally add. In bacterial prophylaxis, if they have a fever, they're already on broad spectrum, and we usually keep them and kind of do the neutropenic fever treatment, so they would be on that for greater than a week. If they have a neutropenic greater than a week, then they consider a fluoroquinolone, kind of standard prophylaxis. We definitely do put them on VCV and herpes simplex virus prophylaxis. Our standards Valtrex 500 a day, or acyclovir you can use as well. This starts automatically. It's in our treatment plan within 7 days of CAR T-cell infusion, and then it'll continue until the CD4 count's greater than 20. And then pneumocystic pneumonia prophylaxis, you start at day 30 and continue until the CD4 count's recovered to greater than 200. Like I mentioned, anti-seizure prophylaxis with levetiracetam, 750 milligrams. We continue this for 30 days and then taper at day 30 to once a day for 3 days and then off for us. And then stress ulcer prophylaxis you may need, especially when you're using those high doses of Dex or methylprednisolone. And then if they're on mechanical ventilation, just making sure you're doing that. I did not mention DVT prophylaxis. I guess you could consider that until their platelets drop below whatever your institutional threshold is. And then growth factor with filgrastim support, starting with CAR T cells. So this is our same patient case. TS is a 41-year-old male with a past medical history of refractory B-cell lymphoma, depression, no known drug allergies, currently day plus 10 of anti-CAR T-cell therapy. His course was completed by grade 1 CRS and headache. You're reviewing TS's discharge medication list. What prophylaxis should he be receiving? I'm not going to read all of these because it repeats a lot. I just had to wait till we get over 200, so we made it. A little confusion, okay. So A, the ANC is 1.5, B is correct, and then C, Bactrim starts on day 30, he's currently day plus 10. Sorry if that was tricky. And D is the same reason as well. The reason why we wouldn't start Bactrim that early is because their counts are recovering, and the theory Bactrim, although low dose, could be controversial, but I think it's easier to wait, and the development of PCP wouldn't occur that quickly, usually in the time course. There's so many logistical challenges. I would love to sit here. We could probably do an hour session on just those. Most people would probably make that frequent headaches instead, because of the challenges of getting this at your practice site. But administering them, the CRS medications in a timely manner, we have ours as needed on call, and the physician just gives approval, and then they're given. The cost of the medications to keep in stock, allocation, and being able to documentation them being sequestered, so the tocilizumab doses. If you have 10 patients getting CAR T cells, you're going to have a lot of tocilizumab in stock, or even 2. You just have to have a way to just document that. The charging and billing is very complex. It requires individual contracts and can be very going through a variety of different mechanisms with the different companies, and it's all separate. And even reimbursement with that and getting financial approval. Many of the insurances haven't added it to their formulary yet, so that can be a delay in therapy. We've had patients where it's taken a very long time to get approval, even to get the CAR T cells. There's the REMS program, so you have to roll out the education, documentation of the education, and have all that staff. So for us, it'd be having floor nurses, ICU nurses, pharmacists, physicians that infuse it. They'll have to be REMS certified as well. So for us, if they're infusing in the afternoon and our clinic physician has clinic, they have to leave the clinic to be at the bedside to infuse it. And then doing the FACT accreditation, they have the immune vector cells, so going through that process as well and being one of the sites. Providing CAR T cell training to the medical team. I have here, we need many specialties, so going through that. The physicians, you'll have cardiologists. Emergency medicine, so the wallet card will help the patients know, let the emergency teams and anyone provider know what they received. And trying to keep the patients close, so they have a trained ER close by as well. So rural patients that we have out in Texas or and even internationally or in a different state, they have to stay locally for a period of time. You have your nephrologists, neurologists. The neurologists are very important in monitoring, doing their assessments. Our team members, oncologists, hematologists, which are the primary attendings, and the pulmonologists if they have to be intubated or develop pneumonia. We have all of our nurses, which play an influential role and be at bedside. We also have caregivers that are at the bedside, and they're really good at depicting when the patient's confused because they know the patient the best. So we like to have a consistent caregiver through that, at least the part when they're having CRS, or could have it, because they usually pick up on it a lot sooner than what we can because of the amount of time they're in the room. We have the mid-levels, which we work hand in hand with, that provide the interventions, the pharmacists on the clinical and operational side. So there's many future directions. More studies are needed to determine especially the optimal CAR T-cell dose, the specific targets. So on the right you have targets, the WT1, which is an AML, CD22, which is B-cell lymphoma, or B-cell ALL, CD33 is a promising target in AML, and the CD229 in multiple myeloma. The co-stimulatory domains, like I mentioned, the generation 3 with the 4-1BB and the CD28. And then you also have the new 4th generation, which I left the best for last, which is the TRuC T cells. So I guess they need to be about like $50,000 to $200,000 then to be called a TRuC, because that's what they should cost. And then they transferred 2 genes. That was a bad joke, I know. It gets worse as we go on, but this is the last slide. So it transfers 2 genes instead of just the 1. Conditioning regimen, we need to determine the doses and the duration of that as well. And prophylaxis, I think we're going to learn what types of infection. We learned the zoster really quick with our first few patients, and then we started prophylaxing, and that's been great after that. And many long-term toxicities that we didn't predict could be a problem down the road. So in summary, it wasn't the last slide, I'm sorry. This is the last slide. The studies are showing promising results for very heavily pretreated, and these patients have limited options, especially in the B-cell refractory phase. They may have a 20% CR rates with any intervention we'll make in a short duration. Trainings needed on the recognition, treatment, monitoring of CRS and CRESS is essential to decrease this treatment-related morbidity and mortality, and there's interdisciplinary teams necessary for the optimal care. I want to thank first the HOPA committee for allowing me to present and all their help in development, being the slides, as well as everyone at MD Anderson, including Sandy Horowitz, Allison Galbus, and Wendy Covert for their assistance in developing the presentation. Thank you, and I'll be happy to take any questions. Yes.
Hi. I have the mic, and then I'll bring it to you.
Oh.
Over here, Brandon.
Oh,
okay.
Sorry.
No. Thank you very much. This was, you really rocketed through it, but you gave us a lot of information. Am I correct then that the current drugs don't have this EGFR trigger turn-off switch jobber? How far away are we from one that, from a commercially available product that does? And it looked to me on the tables that you presented that when that EGFR trigger was present, that the response rate looked higher. Can you comment on that?
Sure. So the availability, the 2 commercially available products do not have the EGFR termination trigger on them. The JCAR017, I think, is the most promising one that should get FDA approval. I'm not the FDA, but I'm guessing within a year, hopefully, would be. Some people are maybe saying sooner with that. And then with the efficacy, I'm unable to make comparisons with the efficacy right now, just because we don't have enough robust data. That's an abstract, so I would like a full publication in order to make the assessment for that.
Thanks, Brandon. That was great. I have 2 questions. The first is related to disease outcomes with the TOSI or the dexamethasone. I know you mentioned that they looked at T-cell expansion, but did they look at disease outcomes or related to the incidence of CRS or CRESS?
That's a great question. So the study with the ZUMA-1 trial, it wasn't powered enough to have that subgroup, but the CR rates were not statistically significant. So we do know that. With outcomes, if you have CRS, it's a good thing as long as you don't die from it, basically. Yeah. It's like a good and bad thing. So that response is showing the cells are expanding and doing what they need to do to clear out the cancer. So I think that's a good thing. We just need to moderate how bad it gets.
Okay. My second question was using steroids with the conditioning chemotherapy regimens. Do you have a cutoff for how many days prior to the cells that needs to stop, or do you not use them at all?
One thing I'm going to add to that, but we do not use it in the conditioning regimen. The cutoffs do vary between 2 weeks and 7 days for that, but you can give steroids as a bridge therapy. I did not discuss bridging, and bridging can be helpful with debulking the tumor, and then that puts them at lower risk. So depending on the studies, they are allowing some bridging, and that is a comparison that I did not make between them, but that will be something that we'll look at too. If you decrease disease burden and then give them the CAR T cells, that might be beneficial. I think there's one back there.
Thank you. That's a follow-up question to the last person that asked. Is there a thought as to what the total, I mean, a lot of people do end up getting steroids. Would you say 30, 50% at some point get some DEX along the way?
It'd be the incidence of grade 3 or greater
Right.
CRS. So depending on this, I keep on prefacing everything with depending on the study, but I would say out of the patients in Hay and colleagues, there was 20 patients that got the combination. That was out of 27. So I think if they have grade 3 or greater, which is about 20-ish% in most studies, but it could be up to 30% as well.
So even though there isn't a lot of information to say what steroid burden begins to undermine the potential effects, is there any theoretical or research thoughts as to at what burden of steroid treatment you may begin to see a diminished efficacy?
No indication right now. I wish they would have published the cumulative dexamethasone or a steroid dose so we knew the burden for that. Because if you can taper real quick, then your burden's less. If you're doing a 14-day taper, you've really increased the burden. So I think that's a great point. That's something I'd like to see. I haven't seen that in any of the any of the New England articles that have been published, the 4 major trials that are available. But
Thank you.
yeah, great question. Okay. Is there any more questions?
Hi, just a quick question. Is there any concern with the early use of GCSF and exacerbating CRS?
Yeah, that's the theoretical concern with it. We have not seen that, which is why we use it so soon. And if you can decrease the period of neutropenia, you'll decrease the infections. But that is a legitimate theoretical, it could be a possibility that could happen. But we haven't seen any. Early on, we weren't using it as starting as soon, but now we're using it at D-1, and that's not thought to be an indicator right now. I would like more lab science on that one, though, because that's a great point. It could, later down we may find that it does, but I think GM, CSF is definitely a no-no. I wouldn't use that throughout any, but we don't usually use it in clinical practice.
Thank you.
Any more questions? Well, I'll be available on Friday. If you don't have any questions, you can stop by. I'm taking brewery recommendations and restaurant recommendations in Denver. It's my first time, so take care.